Good evening, everybody. Welcome back. Another episode of Mondays with Maishi. This is Moshe Norman out of Lakewood, New Jersey, here on the East Coast. It's now 9:01, so just about ready to start. Glad to have you all back. And tonight's topic is a really exciting one. It may be the link that I've been missing or looking for all this time. It's that link between doing analytic, psychodynamic, psychoanalytic work, touching on traumatic incidents, whether they're small t traumas or big T traumas, relational traumas, or incidental kinds of traumas. Sometimes the psychoanalytic work that I do is very helpful. Sometimes it's helpful fairly quickly, in fact, and then other times it stretches and it can go, multiple times a week for just the longest period of time. And my biggest problem with that actually is just the client's pain. The pain that we see our clients or patients sitting in for such a long, extended period of time. The process itself, I think, is beautiful, but how long can we watch somebody endure pain? And the question is, must they? So all kinds of trauma treatments, and somatic interventions and other focuses on how to heal these traumatic incidents are evolving over the past couple of decades. And now there's so many different options and so many choices. So tonight we have the honor of hosting Dr. Robert Moore out in Florida, same time zone, right? But good couple of hours away, and quite a number of degrees Fahrenheit above us, hopefully. So Dr. Moore, thank you, Bob, for joining us tonight. And Bob Moore is a big proponent of what's called traumatic incident reduction, or TIR, which seems to be a very brief intervention, a brief way of targeting trauma. Tell me if I'm getting this right, but targeting traumatic incidents and resolving them without having to go through just those weeks, months, and maybe years of pain and dysregulation that clients struggle with once we touch on the trauma. So Bob, thank you for joining us tonight. Can you just tell us a little bit about who you are, how you entered this field, what your background in this field is, and how you got into TIR?
Yes. Well, background-wise, I come up through the cognitive behaviorist ranks in the 60s. And it was in the sometime in the mid to late 70s that I ran into a program on trauma, which cognitive behaviorists really don't spend a lot of time looking at, actually. I was trained by Albert Ellis, who said, if you can possibly avoid getting into a trauma, you will have your best opportunity to do your work, to do your cognitive behaviors work. But I went to a trauma seminar in the 70s. And short form, it knocked my socks off. I realized that I had a very good grip on the tip of the iceberg. I really didn't have any tools for dealing with trauma at all. And it was then the beginning of a kind of a metamorphosis for me and my thinking. And I couldn't let it go. I just absolutely couldn't let it go. It became very clear to me that the majority of the problems that my clients were presenting had some element of background angst and pain, not necessarily trauma with a capital T, but what has come to be known as adverse childhood experience, various other relational mishaps, and so on. And they wanted to go there, or actually a small percentage of them wanted to go there. And for them, I had no tools. All right. I've learned since, and I've been doing TIR and trauma-related work now for over 30 years. Somebody else come on the line? Oh, okay.
Yeah, we have about 20 so far, over 20 people on, and hopefully. Thank you, Dina, for turning on your video. For those of you who could turn on your video, please turn it on. We love to see you, and we love to have some real attachment.
Yeah, it took me by surprise.
Yeah, and for those of you who can't, we understand that. But if you do want to ask a question, of course, remember to click on the reactions tab on the bottom right of your screen and raise your hand, and we'll take the question.
Oh, that's great. Yeah, I like that. I like that a lot. Yeah. So anyway, I migrated from being the cognitive behaviorist, purist, I suppose, into a keen trauma awareness. And it has been a joy. I mentioned to you earlier, Moshe, that I don't take any credit for it. That is to say, I didn't develop a therapy, TIR or any other, because the work had already been done. Interestingly enough, not too many of our colleagues know of it, although you were absolutely right when you said, God knows there are just dozens and dozens and dozens of different variants on something called trauma therapy. Most of them, I'll make a generalization that's probably not perfect, but most of them are dealing with management of PTSD symptoms, management of whatever difficulties they attribute to their personal life difficulties, how to have PTSD episodes less frequently, how to have them less intensely, so that they can live comfortable lives with what they regard as pretty much a life sentence. I think the popular view is simply that since you can't change history, which is quite correct, therefore you're pretty much stuck with its results. And if you've had a particularly nasty experience, or perhaps even more than one, there's not anything you can do to reverse that. You can't make it go away. So to one extent or another, it's necessary to cope with those unfortunate post-traumatic reactions. And I think that is the popular view, and shared by most of our colleagues, whose services, while excellent in doing what they do to reduce the intensity and frequency of post-traumatic reactions, are still based on the assumption that that is mainly the best we can do. Since you have this condition, you're going to have to suffer with it a certain amount, at least. We're not going to be able to make it go away entirely, because that's the way history is. Now, I'm making that generalization and realizing that not everybody thinks that way, and I'm glad that they don't, because it turns out not to be true. There isn't any trauma that my colleagues have addressed that hasn't been resolved very adequately, so that it doesn't return. And that's the object, not just to manage it, cope with it, reduce its intensity or severity, but to actually make it just simply be gone, absolutely be gone. And
Bob, just real quickly.
Yeah.
My understanding is that there are many modalities, like the most outstanding obvious one would be something, let's say, like EMDR, that claim, with the reprocessing, that the person will actually have new experiences of the old trauma. So it's not just that they are managing the symptoms of the trauma, and
right,
but re-experiencing the story differently, so that those stories can pass through their mind again, but not be traumatic.
Right. And there's some good in that. The formal name for it is reframing. To pass through it and make a few key changes so that it's not as traumatic as it used to be. That's one of the key elements to some of the protocols that are really very helpful. TIR is not one of them, because it's a bit of a stretch at times to reframe, reorganize, reattribute motives and so on to others who are involved in some trauma. And actually, in essence, to change it in some helpful way. I can't disparage it totally, but the better way, in my view, the better way to go is to leave it as it was, as grim as it was, in any detail that the client recalls, without changing it, without purposely, intentionally introducing some kind of ameliorating factor.
Okay.
All right. But I have some admiration for the people who do EMDR well. Although my understanding, correct me if I'm wrong, Francine, um, my understanding is that it works best on a single, one-of-a-kind, isolated, but genuinely traumatic incident.
Well, I'd love to hear from some of the participants. For those of you who are either trained in EMDR or other trauma modalities, have you found that this is the case, or have you found that the trauma actually is resolved through some of the trauma work, where the person will not experience, they can remember the traumatic incident, but don't experience any traumatic responses? I'd love for anybody who is trained and can pipe in to please raise your hand. And while we wait for that, I just want to remind everybody that Mondays with Maishi is now sponsored by okclarity.com, which is the only online platform for wellness professionals who work within the Jewish community to be found online. Their innovative directory allows users to search for therapists, psychiatric medication providers, coaches, and nutritionists for free. I'm proud to have my very own OK Clarity website, where potential clients can find me, and actually have found me just today. We got a referral, or simply learn about all that I do, even if I'm not currently looking to grow my private practice. As a therapist, you know that we despise marketing ourselves, but OK Clarity does that in a really, really classy manner. So if you're ready to invest on your online profile, reach out to okclarity.com and set up a consultation. So I see Ahuva is raising her hand. Ahuva, please unmute yourself. If you can also turn on your video, that would be great. And of course, we understand if you can't, but there she is. Tell us a little bit about your experience. What are you trained in? And
so I am trained in IFS and EMDR. As far as EMDR, what they do work with is a neural network where it's actually not necessarily limited to one particular trauma. One could do that. That would be EMD, and they stick to one particular incident. But otherwise, they could open it up. A person can just go on and on and on to the different. It could be free association, where much healing can come to a whole neural network, a theme of trauma that people have been through throughout their lives.
Yeah, rather more like the complex, what they're calling these days, the complex trauma.
Yeah.
Very good indeed.
And do you find that in fact the traumatic experience is reduced through this, and that they can live peacefully with whatever history happened, that story not having the same intensity or meaning anymore?
Yeah, so the distress level is going to be a lot decreased.
Okay.
Be decreased to zero.
So you may be actually emphasizing Bob's point. Bob, is that right?
Yeah,
the distress level.
In our work, we take it to zero. We're not looking for a decrease in stress reduction, a decrease in stress, or a reduction in frequency of episodes or whatever. We want it wiped totally clean.
Yeah, the distress, whereas the memory can remain, but the distress from the memory will not necessarily remain. But with IFS, I do find that you can actually change the whole experience, because the self can go there to that child and say, what can I do for you? And they can speak to different people that were involved and set things straight so that the child feels safe, that the self was there for them the way they needed them then. And that, so there actually is a transformation of the past.
Yes,
so yes. Really, really interesting.
Yeah.
Okay.
That's what we're going for. As I say, most of our colleagues are quite happy if they can reduce the intensity or frequency of upsets that flow from trauma. But I was delighted to see that there's something else that's really
okay. So let's talk. Let's talk a little bit about TIR. What is this process, and how does it work? And let's see if we can get a little bit of an overview.
Okay, it starts with an understanding of the mechanism that causes the problem. So I'm going to talk about the amygdala for a bit. the common perception is that once the amygdala, which is that little antivirus thing in the corner of your in the tray of your computer, unless you're a Mac user, I suppose, the amygdala leaps out and saves us. This is its purpose, from the insult that we experienced at some point in the past, the trauma or the difficulty that we experienced. That's its purpose. Its design is to recognize, here we go again, and provide the post-traumatic fight or flight reaction that's needed for survival. So that's what it's the antivirus program that's wired into us to recognize whatever has happened may be happening again. Now, almost all of the post-traumatic reactions that concern us as clinicians are false positives. It would be great if the amygdala just was able to see what was going on and to get us out of the path of the onrushing bus and to dodge the poisonous snake, or to, whatever, get out of the traffic of trauma. But it doesn't. It sniffs at what's going on in present time and says, I remember this, that's trouble, get out of here. And it actually, the jargon of the trade is that it hijacks those parts of the brain, the hippocampus, the cerebral cortex. It just shuts them down very definitively, takes over, and doesn't matter that there's nothing really wrong. Doesn't matter that there's no new trauma, that something is definitely amiss. It just moves us out of the way and gives us the sense of having relived an experience that was long gone. And that's the part that people expect is going to track them to the end of their days. And it isn't necessary, because the short story is that the amygdala is reprogrammable. You can ultimately get whatever it is on its hit list taken off the hit list totally. And then we have a circumstance in which they can think about it, talk about it, remember it. It's benign. It's finished. Okay. So I'd like to be able to show it to you, but we chatted about the inadvisability of doing that on the internet. But if anybody has an opportunity to connect with someone experienced in the delivery of traumatic incident reduction, you should be able to see some videos of it. Okay.
Okay, so can you give us a bit of an overview as to what it is that it's looking to target and how we target these traumatic incidents? In other words, if I were to use psychoanalytic kind of work, and I have some relational trauma, client with relational trauma between her and her mother, and she has this pervasive sense of inadequacy because her mother was borderline and constantly putting her down. I'm just oversimplifying something,
Yeah.
And there may have been, particular incidents where her mother really yelled at her or put her down in a traumatic way. So what does TIR look like? Well,
for starters, the client would be telling that story using their own idiom. It's not uncommon for us, for clinicians, to translate a story like that, a perfectly good, realistic story, into a diagnosis, particularly when the client is eager to get it. What's wrong with me, for God's sake, that kind of thing. It sounds like you suffer from whatever it is, and put a label on it. Very useful for the insurance company, but it doesn't clarify anything in the clinical setting. So we insist that the incident, its effects, are exactly and only what the client says they are. So we use their idiom. In fact, odd as it may seem, the word trauma doesn't come out of my mouth as a clinician until or unless the client uses
Uses
it.
it. Mhm.
Okay. I don't ask, have you ever been? Even on an intake interview, there's no item that says trauma. Give me all your traumas. Okay. If they have something in mind that fits that, what most people think of as traumatic, they'll let me know. And whatever they let me know is what we call it. Okay. We don't call it anything else. And the feelings they're having, the same thing. Somebody can come in and say, God, I have to get up in front of somebody and give a talk, and I'm never good at that. I get all squidgy in the stomach, and I just can't really, I fall all over myself when I have to stand up in front of a group. And it would be the most absolutely normal thing to say for a clinician to say, oh, sounds like some bit of performance anxiety there.
Right.
And the client would immediately say, yeah, of course. And what they've done is they've just shot themselves in the foot, because when it comes around time to figure out where all that stuff came from, it's not going to be performance anxiety. It's going to be squidgy in the stomach.
Mhm.
Okay. Which behind the moment it came out of the guy's mouth.
Mhm.
So we're very particular about using only the descriptor, the descriptors that the client uses.
Mhm.
Descriptors of the events, descriptors of the feelings, emotions, reactions, whatever they say it is what it is.
Mhm.
Because that's what's embedded in their memory of those experiences. Okay. Extremely important. So in this sense, the client, the counselor, the therapist is stepping out of that picture and not contributing to its formation, its definition, its diagnosis, its the shape and size and impact of it. That's entirely up to the client. The client may have revealed all kinds of horrible, genuinely horrible experiences. And if and when they come around to wanting to deal with any of that, they are also allowed to pick and choose where they're going to start and what they're going to do next. So you can know that absolutely the fact that they saw their family slaughtered or something really grim, when it comes time to use the clinical procedure, in which, by the way, they've always been pre-trained, when it's time to do it, what would you like to look at? What is it you would like to address to start? And they come up with, well, cockroach crossed my kitchen floor the other day and I freaked out. Okay. And that's where we start. Okay. There's a all roads lead to Rome mentality associated with this. They're going to address something that's either impinging on them now or that they can handle now. And if it's a whole lot simpler, in a sense, then some of the things that are in their history from other things they've said, it doesn't matter, because we're just going to peel them away one at a time in the order of their preference. And there's no way to avoid getting where we're going to need to go to deal with some of the heavy duty stuff. Mm-hmm. So it's a TIR is a highly person-centered affair. They define the problem. We use their idiom, their vocabulary, their sensibilities, and never refer to it in any way that they don't. And when it comes time to address it, we address it with in the order of their preference, in the order of the events that they present for intervention.
So can you contrast what are we doing differently than, let's go back to, psychoanalytic or psychodynamic kind of work where we're looking back at the old story and basically rehearing the story in a very supportive and supportive way, in a holding environment. What is TIR doing?
Well, it's what TIR is not doing. While that's taking place, you describe it very well. We hold them, we provide a space for them, a safe space for them to readdress the experience, the chosen experience
Mhm.
for the session, and simply allow them as a guide to review it and tell about it, and review it and tell about it, and review it and tell about it. Okay, but that's done. You use the word supportive to describe the counselor, the therapist, for sure. But that's not manifest in words of encouragement, judgments, attaboys, attagirls. Tell me more about that. That's good. How did that feel? All of those things that are so normal for our profession, totally absent. Totally absent. That's intrusive. Okay, or more precisely, that's hippocampal. Okay, that's the way two people relate. That's the way someone expresses compassion and love and caring and helpfulness and so on. And it's my head to your head. It's hippocampus to hippocampus. And when you're immersed in a traumatic experience, you are being pushed around by the amygdala. And anything you do that's hippocampal, any dialogue you want to have, any support that is given as words to which they need to understand and respond to, blows the procedure apart. So it's a very the counselor's role is a very low key one. The counselor is the guide in helping a person to go through the experience, but contributes no observations, no encouragements, no questions, no supportive, loving, caring, I'll get you through this kinds of stuff. Okay, which is so many people think of as the heart and soul of what we do. Okay, but when a person is absolutely captured by something worthy of a trauma session, they're now in the grip of the amygdala, because it invites that re-triggering. Just talking about it, thinking about it, invites it back. It's like asking for the amygdala to jump in and take over, and they're in the midst of that for at least a while in the session. And that is what is precious, because the healing part is when the amygdala, I have to anthropomorphize these guys, when the amygdala gets together with the hippocampus in a soundproof room, so to speak. We're on the outside just giving occasional move through it remarks. When the amygdala and the hippocampus get together to look it over, the amygdala is coming on like, this is a terror I have to save them from. And the hippocampus is the touchstone of reason. The cerebral cortex is the intelligent day-to-day operating mechanism we have when we are supremely, what should I say, competent. We are not being driven by any old experience of this sort. So we get them together in the same room, so to speak, the amygdala and the hippocampus.
And you're saying we get them together just by not interfering, or is there a way for us to help them meet up?
Well, the only way we help them to meet up is by accepting their invitation to address this experience, and having trained them in how to simply review it silently, mentally, and then tell us about it. Okay? So that's how we get them to meet up.
So we're having the client or the patient review the incident in their mind first, quietly.
Correct.
And then replay it or repeat it verbally.
That's right. Yeah.
And what's preventing the hippocampus from being shut down by the amygdala?
Nothing. It happens right in front of you, right, absolutely routinely. That's what happens.
The hippocampus gets shut down from the anxiety?
From something. In other words, if it was a real significant kind of an upset, a traumatic experience that took them out of their normal composure, and you ask them to review it and tell you about it, you're going to see them lose their composure right in front of you, to some degree.
Mhm.
not so standardly that we can know that they're going to be jumping up and down or screaming and hollering or crying or whatever.
Mhm.
But we know that they're going to be in the grip of this programmed reaction that the amygdala provides for their safety, to get them safely out of here. Kind of ironic that that motive produces such strong reactions. But you can expect it, and we expect it. And now most of, again, one of my generalizations, most of the training we've had as clinicians asks us to ground them well enough so that they don't lose their cool, so that they don't become totally upset and bleeding on the carpet and so on and so forth, because we want to be able to help them, relate to them, talk to them, and so on. So there's a different motive operating there. We don't, in TIR, if you want resolution, you can't afford to have that motive. You can't afford to save him from it, the client, because if you save him from it, you pull him out of his upset, and you see that he's collapsed into total amygdala speak, and the hippocampus has been set aside, if you like the neurologic stuff, and you don't want him there, okay, then you're not going to have resolution today, all right? Because the only way to get it is to let them have that dialogue. There's an inner dialogue taking place in which the amygdala is announcing, recapitulating, rehashing how bad it was, and the hippocampus is essentially saying, "Oh, come on now. That was then. This is now. Here's what was going on," and sort of like the rational view of what the amygdala is trying to save them from. And you hear it in what they tell you, when they review it and share what happened, because it starts out kind of tentative, gets quite strong as a rule somewhere along the way. If it was a powerfully upsetting affair, some of that comes through, and then gradually the influence of the hippocampus over the amygdala begins to be prominent, and it comes through. So there's a curve from a gentle restimulation to the maximum restimulation that this incident will provide, down to what in TIR is simply called the endpoint, of the procedure. And the endpoint of the procedure is really quite remarkable. And you don't see it unless you have essentially brought that stress level down to zero. And it's quite remarkable to see them go through a high degree of upset, come down to the 0 point, because when that happens, there's a neurologic reflex that takes place. There's a one very specific moment in their account of this thing when they simply say, "Oh, this is so much nonsense." Now, this my little glib "this is so much nonsense" remark is like 20 minutes or an hour after thinking that their head was going to explode. And they'll make reference to that. They'll make reference. I can't imagine that a few minutes ago, a few hours ago, whenever it was, and I thought I was gonna die again. And now it's over. It's just over. And there's a reflex that takes place. And typically they break out in a mile-wide grin. And that's it. You couldn't bring that back to a post-traumatic level if you wanted to. It's been done. It's gone. And that process doesn't honor the fact that the insurance company is only going to pay you for 45 minutes. Okay.
Got it.
It takes as long as it takes. The average session is probably about an hour and a half.
Oh, well.
It's sometimes a little shorter, sometimes a little longer. But we don't go home. We don't go home until it's done. So there is no second session on the same incident.
Oh, I see. So you want to resolve any given incident in one session?
Want to? Do. we stay there until it's done.
Well, it's done.
Yeah, and they know that. We don't do this with anybody who hasn't been thoroughly trained in it and met all the prerequisites and all of that stuff.
So Bob, could you give us a sort of overview as to what a session actually looks like, either through a demonstration with someone here in the audience, or kind of describing what a patient, what's going through their mind, what are they saying, and then what is the therapist or the counselor saying? You know, I know you said that we try to stay out just to a large degree, but how are we walking them through the session? What's our role there in the session?
Well, with the understanding that the client has been trained in his part, my part, that they've been essentially given a dry run, you know, the expression, up in advance of dealing with their real history. They've just an imaginary scene in order to get all the instructions in place, so that if I'm the counselor, if I say to you, when was it? They know I was 14. Good. My part is to say, when was it? Your part is to answer that question. Where were you? In the living room. Okay. Okay. Good. And if there's any question about it, it's all very literal, very simple. So we have somebody who has gotten trained up in the procedure in this way, so that when we come to dealing with it, they choose what they want to deal with. That is to say, they select the incident.
Mhm.
Okay. And I say, and all the conditions are met. They're well fed, they're well rested. We got a couple hours, and they say go. All right.
So wait, I just want to make sure I understand. You're
Yeah.
saying that the client is sort of pre-taught certain rules about how the session is going to go. Is that what you mean?
We don't
primed?
consider them rules. It's just the procedure. The procedure.
They're primed with the procedure.
Yeah. It's like here's what we're going to do.
Okay.
Here's
And so
we're gonna do.
what are those things? Well, I'm going to ask you.
Yeah, I'm
You're
going to ask
you're going
you.
to give me permission. You're going to tell me what incident you want to focus on, and then when I ask you questions, they're going to be simple, short, to the point, and just answer them literally, without
Yes,
getting too
exactly.
detailed.
Right, and they're just a setup. You know, when was it? Where were you? What do you see around you? What's your environment like?
Okay.
Good. And then go to the beginning of that incident and tell me when you're there. Okay, this is where the silent parts is set up. Go to the beginning. Okay, feel free to close your eyes. Most people do. It's optional, but we say, just close your eyes, forget about me. Just go to the beginning of the incident. Tell me when you're there. And they give me the nod. And I say, move through to the end of the incident. And they know, they have been taught, they know that means silently review the thing and tell me when they're done. And I just sit and wait. Okay. And they go through and they go through, and they do whatever they do in their heads. And then finally they say, okay, I'm done. And I say, tell me what happened. Well, and then they, tell the story. And when they're done, okay, when they're done, and part of the setup is knowing what the duration is, whether in minutes, hours, days. It's not usually it's usually a short period of time, minutes, hours. Some people who initially think, I was in the hospital for weeks. Well, okay, that's separate. We'll just take the core of it here. Okay. And when they've told me what happened, return to the beginning of the incident. Tell me when you're there. Okay. Good. Move through to the end of the incident, and they silently go through again. Tell me when they're done. Tell me what happened. Good. Move to the beginning. Tell me when you're there. Move through to the end. Tell me what happened. Go to the beginning. Tell me when you're there. Move through to the end. Tell me what happened. Okay. And that's it. That's the core steps. Go to the beginning.
Now are the incidents,
there.
when they're reporting what happened, are we seeing changes in the incident, or
Oh boy,
changes?
oh boy, oh boy, oh boy. You should. If it were really literally word for word every time, you'd know that there was something stuck. Doesn't happen very much. Okay. the changes are just part of the process. This time, then, and then he said, and I remember now that, change. So that's the one way, the one very most important way the counselor knows that progress is being made. And that is simply that there is change.
Which the story is changing. And
just
I assume the
doesn't matter
affect, I'm
Pardon?
assuming the affect changes too.
Oh yeah. Because it goes from being just a low level, usually strengthening somewhere along the way when it's most intense. Okay. And then gradually it dissipates, and with the changes. Okay. Move through, tell me what happened. Move through, tell me what happened. Move through, tell me what happened. And meanwhile, their curve, their distress curve, is going for an endpoint.
Okay.
And when the endpoint comes, it's like they're at a very low level of stress. They light up. Basically, they light up and say the most absolutely remarkable things. One of these days, I'll separate out the audio track and share some of that with you. I can't. I would love to be able to show it to you. Okay, but it comes through very, very crisply, very clearly that they're finished.
Boom. You can tell.
And it comes with a big grin.
Like a huge sigh of relief.
Oh, huge.
Yeah.
Absolutely huge.
Yeah.
And happy relief. Kind of like, I never thought I would ever get over that. And
then you're saying that this never comes back as a traumatic memory or incident.
No, it's done. It's done. It's like the amygdala has
resolved.
done 180 and left the building. Yeah.
Yeah.
It's no longer on the hit list.
Can we take a question? Ruth has her hand up and I don't want her blood to stop circulating. So can we take a question from Ruth? And thanks for jumping in, and for all you out there, feel free to jump in with more questions, but go ahead.
No.
Hi, thanks so much for presenting. This was really fascinating. I just wanted to ask, it sounds sometimes a little similar to progressive counting when you're playing that movie in your head, but you're doing it and from a short amount of time to longer and longer and longer, and then back to shorter amount of time. You're playing the incident like you said in your mind, the client is in their mind, from beginning to end, and then we're just giving them more and more time to do it, usually doing some bilateral kind of tapping while they're doing it. Is there a lot of crossover between that and what you're doing?
Well, it sounded very similar until you got to the tapping.
Oh,
Because
progressive counting doesn't do tapping, does it?
So truthfully,
Bob, you 1 second? Progressive counting is a very, very, very new intervention. I think so. I actually put that question in the chat, Ruth. I don't know if you saw a couple of minutes ago. I asked if anyone is familiar with progressive counting. It does sound very similar, but Bob, are you familiar with progressive counting?
No, I'm not.
Yeah, I think that's a rather brand new, fairly new.
I know it was presented at the Nefesh conference a few years ago.
I mean, it's fairly new. It's Ricky Greenwald.
Yeah.
Yes, Ricky Greenwald did it. But so I guess what I'm asking is that a lot of times it seems very helpful for an incident, like one traumatic incident. But if the trauma has been repeated, a few times, if there's been abuse or something that's been repeated a few times, would you say this is an appropriate approach, or it's not really good for trauma that's kind of been repeated quite a few times?
We have two protocols. One deals with the, what should I say, standalone incident, the one of a kind. And the other deals with incidents that have antecedents, which is what you're describing, something that has happened many times, or even different things that have a common theme. Lots of things have scared me to death, So if they're not, a lot of people don't present a trauma or even use the word very much, but will present the reaction that they are not enjoying. God, I have panic attacks. I don't know where they come from. I just have panic attacks and they're horrible, just horrible. I have panic attacks. And they don't say anything about history, just that periodically they have panic attacks. Well, they weren't born that way. You know, they didn't go through life that way. I'll give you, this is not part of TIR, but there's a wonderful little question that one can raise to kind of get them on the thinking in terms of what could really be going on. Thought just came that I should say the PTSD folk who walk into your office, if you're a clinician, represent by actual count. I'm not making this up. These are on record. 7% of our clients. I mean, unless you have something over the door that filters them. 7% of our clients walk in the door and extend their hand and say, "I'm Smith. I'm here because I've never gotten over the train wreck." PTSD. Okay, they know their PTSD. 7%. That leaves 93% who say nothing about prior trauma as a reason for going for therapy. 93% of the general population who are service seeking do not call themselves PTSD. So only 7% do. So for all the others, they've got a background that has caused them to have the problem they're seeking help with. Now, I just made up panic attack, common enough, but they'll have them not point to any particular occasion that created that reaction pattern, or they'd be PTSD, right? They'd be part of the 7%. But the 93% just say panic attack or whatever they have. And the simple question is, how far back would you have to look in life to a time when that wasn't true? And if you felt today the way you felt then, you wouldn't be here in my office. So now I want to point out that's not like, when did they start panic attacks? When did you first notice you were having panic attacks? No. No, this is a different question. Not when did you start having panic attacks? How far back do you have to go to a time in your life when you were just simply happy-go-lucky, everything was wonderful, you were feeling great? And they'll always answer that question. Oh, yeah, when I was a kid, yeah, it was fine. You know, junior high school was a gas. Or I remember my first job, I was on top of the world. So they'll pick a time zone that was memorably really great. Good, thank you. That's all I want. Thank you. Good. Then this panic stuff came later, right? Yeah, got it. Because when they walk in the 93% and have no explanation for it, they tend to provide one. My mother was like this. It's got to be hereditary. I think it's genetic. It's in the blood. It's in the family. Oh, my father's a bear too. Yeah, everybody. You see, they're making it. They're trying to find a reason why. Now they're in your office, knowing you're not going to be able to change their.
So they're giving you an answer without you asking a question, right?
Yeah. Oh yeah. Yeah. They come in with no mention of trauma, but they have some idea that this problem I have has to have come from somewhere, and they've provided for themselves all the wrong answers. So all I do is I say, take a look back to a time when everything was really super. You know, you were a happy kid, you were a happy young person, whatever. And they always do. Very, very, very few people ever say, no, I rolled out of the womb having panic attacks. They don't do that. They just don't do that. Because if they did that, I'd say, really? Really? Oh my God. And if I do that, they'll say, well, no, not actually, but, you know. So you get them to understand that the good piece of their lives was fine. Okay, great. That handles the hereditary, genetic, in the blood, and all those other things that you've been kicking around as probable cause. Because you were fine then. Something happened along the way. Okay. Now, TIR addresses that with a protocol that's a little bit different than the one that we use on the 7% who walk in and say, PTSD. Okay. I mean, they just hand you the incident on a silver platter. I've never been the same since this. Great. Well, we have a protocol for that. And they will go home without that problem today. No, well, not today. I mean, when we get around to dealing with it, right? Because there's going to be some sessions in which we hear everything they have to say, get them trained up, ready to go, and so on. But the more complex, the 93%, and anybody who has a lot of difficulties, as you were saying, Ruth, the people who have stuff in the background, multiple. That's what complex, by the way, if a client ever asked me, insisted on having a diagnosis, I would never use the word complex in front of them. Okay, I don't want them to infer, oh my God, my problem is complex, right? I'm never going to get out of this. Horrible. That's why we don't feed into that fear. All it means is multiple, basically. Complex really means multiple things that have happened over and over and over. I had a really crappy life. This person, that person, this experience and that experience, all tied together and so on. And it's true, if you run the regular protocol of just, okay, you pick one, the client picks an incident, and we do the review it, tell me about it, review it, tell me about it, review it, tell me about it. If it's not linked to something earlier, it will go to an endpoint right there in that session, because there's nothing else feeding it. If, however, the incident we are addressing has gotten some of its figurative juice, stress stuff, from prior history, from earlier incidents that they haven't yet mentioned, that puppy will level off and stay strong, okay? And the protocol simply understands that, allows for that, and we work our way back. If this wasn't the first time that you've had it, whatever we're talking about, there was an earlier time. What was that? When was it? You know, where were you?
So that's where those questions come in.
Yeah.
So are you saying that the client is going to, by default, bring themselves back to earlier times?
Help me out with the default part.
In other words, just by virtue of going through the process, will they remember earlier times and bring
you betcha. You betcha. I would be so happy the day that I can share that with you and show you the video of how that happens.
We're going to make that happen, Bob.
Yeah. It's quite wonderful. I tell you that, it happens in so many ways, in so many different so many different times. But what just came to mind was a lady who, in fact, happens to have had panic attacks. And interestingly enough, and she's had them all her life. She's seen all the therapists in town, took in every drug known to God. She's still having panic attacks. And she came in and learned about what we were going to do, which nobody had ever done. Of course, no, we're doing something that's not popularly done, hadn't been for years. She came in and said, well, the most recent one that was really is when my colleagues at work took me out for lunch because it was my birthday. They said, come on, we're going to take you out to lunch because it's your birthday. And they did. And she sat there at the table, you know. She could hardly speak. She said the peas were rolling off her fork. You know, she was just totally in the grip of anxiety, her panic attack. And that was like maybe 6 weeks earlier than the session we were having. And so that's fine. When we get around to it and we get her trained up, that's where we start. She invites our attention to that. Good example of it right there. Okay. And she's talking about that. And then right in the middle of it, you know, that reminds me of, and she's just hopped back to an earlier experience. Okay. My role? When was it? Because I realized, I know this, there's nothing dangerous. This is the amygdala's job, save us from danger. There's nothing dangerous about being out to lunch with your colleagues. False positive. So I knew there was something. And she just said, you know what? I just remembered something. I said, when was it? And she said, I was about 5. Okay, she went from six weeks ago to 5. All right, I mentioned that because usually there's some good number of incidents in between. So she goes back there and unravels a story about what was going on in her family that scared the bejesus out of her. And in the middle of that one said, "This isn't it. I'm remembering something earlier."
Mhm.
Okay. When was it? And she couldn't even answer the question before she was just immersed in rats. Okay. You'll see this in the video. She was sitting at a dinner table with mom and dad, and all of a sudden a horde of rats came down out of the attic and overran the dinner table. Just
I think I'm going to have trauma after this.
yes, it was quite a remarkable story. But all we have to do is get on the wavelength that she's on and turn it on. I don't take credit for that. You ask somebody to look at something that's really upsetting, the amygdala will turn it on. And so she's in that condition. Now, if whatever we're looking at had no antecedents, nothing earlier, this was a standalone, she'd have been through that to an end point.
So Bob, I just want to
Period.
clarify one thing.
Yeah.
What if we're not discussing a traumatic incident? Suppose we're just discussing panic or anxiety or relational trauma that was just pervasive, constant chaos at home or criticism or whatnot.
Yeah,
right?
yeah.
So
Yeah.
how do we begin the process? And then it sounds like somehow it's going to be taken back 2 incidents, if I'm getting this right. It's going to, as the client is processing it, there are going to be incidents that come up, presumably.
That's right. That's right.
So how do we start the process if we're not starting from an incident?
Well, you are starting from an incident. You're letting the client identify the referring, or rather the presenting complaint. All
So
right.
the presenting complaint is a constant chaos at home. Are we going to have them remember a particular incident?
No, if it was just chaos at home, they wouldn't be in your office.
Okay.
Okay, because that's their problem. Oh, those idiots! Look at the chaos.
Mm-hmm.
No, it's what's going on in here with her.
Mm-hmm.
That's what drove her in.
Mm-hmm.
Okay. Now I can't use her words, but if you there was something going on with her in
Mhm.
response to the chaos at home. She was embedded in it. She was involved in it. She was experiencing it emotionally, personally.
Okay.
It
But
wasn't.
that's not an
somebody-
incident. That's not an incident either. That's an experience.
Yeah, it's a personal emotional experience.
Yes. So how do we get into the process of the TIR when we're discussing an experience and not an incident?
Well, you'll be asking, if she doesn't tell you spontaneously, it would surprise me. You don't have to do anything more than, how may I help you? Why are you here? Okay. It's like day one. I'm not here just because of something they do. I'm here because
So let's take a case in point. I'm here because I constantly feel a complex in front of other people.
feel what do you say?
I constantly feel a complex.
A complex.
I have this complex in front of other people, like the sense that I'm inadequate or that they're not interested in me.
Mm-hmm. Yeah. Anything else you'd like to tell me about the complex?
I mean, I'm always afraid to insert myself in a conversation because I just feel like I don't belong in there and I'm just a nuisance.
Uh-huh. So there's some strong feelings involved.
Yes.
Yeah, if there weren't strong feelings involved, she'd just be telling a story about somebody else's foolishness.
Right.
Right. So you zero in on what feelings she's having, or reactions or whatever words she's using, that she'd rather not have, that she'd like to get rid of. She wouldn't like.
So can we role play it? I'm feeling really overwhelmed when I'm in these social groups where I want to insert myself and be part of the conversation. But I just feel very overwhelmed and like ashamed to speak up because I'm afraid that I'm going to be rejected.
Okay, very good. And what we just pause there for a moment, because what we'll ultimately, or in this department, we will teach the client to do is to break down a reaction that's being called overwhelmed into what, if any, component parts it has. Okay, component parts of a reaction are referred to in this area as FESAPs: feelings, emotions, sensations, attitudes, pains. Anxiety is not really a good run of, or panic is not really a good item to run to the procedure on, because if you round up a dozen people with all who claim correctly to have anxiety, they'll all give you a different symptom cluster.
Right.
Yeah, the symptom cluster will be different.
Right.
So we always routinely take whatever word they've used to describe an emotion and make sure that it doesn't have subdivisions. All right, that it doesn't break down into FESAPs: feelings, emotions, sensations, attitudes, pains, and have them describe, oh, this overwhelmed business. Oh yeah, I throb right here, and I feel like my heart's going to come out of my chest, and et cetera, et cetera, et cetera. And so after they lay out all the component parts of the reaction that's driving them nuts, we just ask them to pick the one they most want to address or to start with. So they're zeroing in. They start with normal use of language using broad terms, and this is where anxiety and panic become broad terms. Overwhelmed, absolutely broad term, and they learn that they can carve that up, slice it and dice it, or have already done that in their own way. And you understand, we're not providing multiple choice. We're not telling them, well, is that one of these or one of those? Just ask them, what's that made up of? And when they come and zero in on it, okay. Oh, the lady that I told you about, it was a lady, the one who went out to lunch with her friends and had a panic attack and wound up with some rats at age 3. Okay. Her presenting the panic thing, what it boiled down to, what the addressable item: shaky hands. Shaky hands. I couldn't have made that up. What signifies, what's the core reaction to this thing that you're calling panic? Shaky hands. So for the rest of the session, is there an earlier time when you had shaky hands? An earlier time when you had shaky hands?
Do you ask that question?
Yeah.
You ask.
Well, that's at the point where she needs to go from whatever incident we're looking at, which typically is false positive, benign, ergo not the cause of the problem, to something earlier that is more likely the cause of the problem, something earlier. Okay. Lunch with your colleagues doesn't pass. That you can't resolve something that doesn't have a whole lot of intrinsic pain-producing, stress-producing charge on it. And that's a happy time for most people. If it's not a happy time for her, there's something in that scenario that has triggered something earlier. Ipso facto. Has to be. It's coming from somewhere. So if she's not born with it, and this was not a dangerous situation, being out to lunch, the reaction she's having here has its own history. So an earlier time when you had shaky hands, her choice of words, an earlier time. Now, in this particular case,
so
she
I
upstaged me by just announcing it.
So let me make sure I understand this then. I think what you're saying is that if a person presents with what they're calling anxiety, depression, relational trauma, etc., we want to break that down to something symptomological, I don't know if that's a real word, but where we can take something concrete, because the word anxiety is very not concrete.
Exactly.
It's a description of almost every neurotic experience.
Exactly.
And so we want to break that into something such as, in this person's case that I'm thinking of, my face gets flushed and I feel my heart thumping, or my heart beating very quickly.
Yeah.
And that's where we want to go back to and look for earlier.
Except I wouldn't combine them because they're separate. Face
Yes.
flush and chest pounding are separate. So it's their choice, always their choice, always their choice. Give me the one we want to address now. We can always come back to the others.
Okay.
Today,
Got
you
it.
know?
So that's where we're going to get earlier incidents from.
That's where we're going to get
symptom.
earlier incidents. Yeah, we
Got
use
it.
that to trace. That's why the importance of not saying, "Oh, well, I see that you have performance anxiety." You change the subject. You just, I'm going to run your language for you here.
Right.
And now you lose the opportunity to trace.
Okay, this is great. Okay, let's take a question from Elliot Kaplan. Go ahead, Dr. Kaplan.
Yeah, you use the term trained up a number of times. I'm interested in what that
I
means.
missed it. And you used what term?
Trained up.
Oh, trained up.
Yeah, what does that mean?
Means I'm from New York, I guess. Trained up, yeah. That's when we spend at least one whole session introducing them to the protocol we're going to be using, step by step by step, so that, and we rehearse it. Okay. It's a little bit like what I imagine ladies go through when they're pregnant the first time and they're talking to their obstetrician and they want to know what's going to happen when my water breaks and I have to go to the hospital and I'm in the middle of a party. And then, okay, all right, let's talk about the process. Okay. And there's steps here, and they have to learn what it means when I say push, what it means when I say don't push, and why, and what you're supposed to do if I say breathe, or whatever. We just give them a lot of detail about step by step by step by step, from the time your water breaks to the time you're holding your new infant at your breast. There's a whole bunch of steps in there, and I've done them 1,000 times and you've never done them. So let me, groove you in so that you know what we're going to be doing. So that's just my analogy. It's kind of like that. We have to teach them what this protocol is all about and why they're going to be doing what they're doing. And the questions are very simple, very elementary, very plain language, nothing fancy. Tell me when it happened. Where were you? Move through, imagine it. Tell me when you're done. Tell me about it. Tell me what happened. Go back to the beginning. Very simple, plain language stuff. No judgments involved. And when we have them really understanding that process on some other session, some other day, some other session, what would you like to address first? Now, they've already given me a whole lot of background about how miserable they were. They've told me about some nasty history. I've already trained them in this technique. And once again, I'm saying, where would you like to start? No assumptions.
Now, have you ever had a client that that for whatever reason you couldn't train them up? That, in other words, the client might be so self-involved and have ADHD that they can't really focus on what.
Oh, yeah, sure. We can take a step back and say that not everybody is eligible for TIR.
Okay, so
not everybody. No,
okay, so
they can't be psychotic. They can't be on drugs. They can't be alcoholic. Actively drinking.
Okay.
There are a lot of those things. They have to have their wits about them. They can't be under drug control. Yeah, and they have to be reasonably lucid, and absolutely, they have to. If they don't meet those qualifications, then they need a lower level of entry point into their case. There are some. There are lower level entry points into cases. This one requires some cognitive ability. All right.
So those clients you would refer out, I'm assuming.
No, we have other tools. TIR is just one tool in the basket.
Oh, I see.
Yeah.
Where is the place of the hippocampus here? Because you had started talking about, the merging or the synthesis of the hippocampus with the amygdala, and where's the
Yeah.
hippocampus playing a role here?
Well, the hippocampus is there are lots of other parts. The hippocampus and cerebral cortex and probably a few other components of the brain are responsible for our good, normal, healthy, logical, reasonable, thoughtful way of functioning. If we were always totally in the control of hippocampus and friends, nobody'd ever think we had a problem, and neither would we. Okay? It is the voice of reason based on everything we know. Our full maturity and capabilities are expressed in that way. Now, the amygdala is designed to spot danger. And by the way, it doesn't come through pre-programmed from the womb. The amygdala, and you know this, I'm sure. The amygdala has to be programmed. We have to have experiences in life that we understand to be dangerous to us, and instruct the amygdala in the process. So the amygdala is taking notes. And if we experience danger, the amygdala takes a snapshot of every sensory component in our bodies, so that if anything like it, at all like it, anything that resembles the picture we give of what was dangerous should occur in the future, the amygdala will immediately alarm us with the fight or flight juice, so to speak, and help us to get out of that situation, because our own history has informed it. And that's what most people believe the amygdala can't be persuaded not to do anymore. It hangs on to that programming against every effort to talk it out of that, which doesn't work. So I bring the amygdala into play here in this description, because in the procedure that we're using, we're allowing somebody to address an incident that kicked them out of their hippocampal control into a sense of danger or upset or something like it, that the amygdala has made good notes about because it's been bugging them ever since, in one way or another. And we call it, we run that incident. We allow them to recreate it, tell about it repetitively. All right. And that turns on whatever is there, whatever it's got, whatever juice it's got gets turned on. At that point, the amygdala is in front of us doing what it did originally and every other time they had an episode, hijacking the hippocampus. And it does that beautifully. It turns an absolutely bright, normal, compassionate, loving, wise, intelligent person into a babbling idiot in milliseconds, because danger is like that. Bang, the amygdala has taken over. It's just astounding. Okay. I'm reading some literature now about how that shows up in some of our medical colleagues' testings. In any case, the amygdala and the hippocampus in the course of this procedure simply get together. The amygdala is ahead of the game, because it's just reviewing this thing, this horrible thing, is an invitation to invite to have the amygdala start doing some bashing, and it can be strong, and the hippocampus gets flattened for a while. But gradually, as they go through the procedure, the hippocampus, since the amygdala can't win the argument that this is still dangerous, because it isn't, this is a false positive. Okay, what's been happening in the 20 years since the train wreck? All false positives, okay? But that doesn't mean anything to the amygdala. It's just doing its job. So gradually in this process, what happens can't happen anywhere else, because nowhere else in the person's waking experience would they ever do anything like this. And let the amygdala have its way, until the hippocampus finally got hold of it and revealed that this is over, it's done, you're fine, right? Whatever. And the amygdala just says, you know what? You're right. This is your business. This is not my business.
So
This
it
is
sort
your
of
business.
takes over at that point.
Yeah, it's done.
So one last question. What happens if you have, does this ever happen that you'll have a client or patient who is becoming too deeply engrossed in their sympathetic system and they're too triggered while, do you have a protocol for a client who's just getting too triggered and too overwhelmed?
I don't have a definition for too triggered. See, that's a judgment, which if I made it like most of our colleagues and I did years ago, we would stop the process.
Mhm.
We would ground them. I have had a room full of our colleagues in a continuing education presentation in which I was showing videos. It's why I now introduce the videos after a very thorough explanation of what I'm going to show them. Because if I show the videos to them a little too soon, they freak out and say, "Why the hell are you letting that happen? Oh, Jesus. What kind of therapist are you?" He's all upset. I'd ground him in a heartbeat.
Mhm.
Meaning you would cancel out the clinical process and he'd go home with the same problem he came in with.
Mhm.
Oh,
This
so
is
there is no too much. There's
what if
always
they're
exactly
dissociating?
enough.
What if they're dissociating?
Sorry.
This is what's so greatly contended today. What if they're dissociating?
It's just a fancy word for very, very upset. It's gonna
And so
happen.
you'll let them. You'll let them. And what if they don't come back? So in other words,
No. What do you mean come back? Come
so in
back
other
from
words,
the session?
you can have somebody remember the incident and then become so deeply engrossed in the trauma of the incident that they dissociate and don't come back to describe what's happening for them.
Where did I lose control? Where did I go wrong? You see, if they're doing what we rehearsed, if they're doing what they understand the protocol to require, they review it, they tell me about it, and at the end of each of those steps, they tell me when they're done, so that I can just simply say again, return to the beginning.
But clients who are dissociative will start reviewing the incident, the pain and turmoil that it brings up for them.
Yeah.
Will compel them to try to regulate themselves. They may dissociate and then not come back and repeat to you what's happening.
Oh, they will eventually.
It will
They will
eventually. So how
eventually.
long would you let somebody sit in that?
Well, pretty long. Kind of, it's a judgment call based on what we know about what turns it on, what turns it off. Okay. And you're describing of somebody who just jumped into the deep end of the pool and is floundering and floundering and floundering with a lot of emotional pain.
Mhm.
Okay. Now, there is no danger. Whatever it is they're describing is ancient history. They're in my office.
But
Where
it feels very real and present.
Oh yeah. That's what
And
we're.
you're
see,
okay with no matter what degree of discomfort or pain the client's in, we're okay with that.
We're okay with that because they elected it. Where do you want to begin? What do you want to address?
Okay, but they may not have realized how much pain it's going to put them through.
That would be yeah, it may not, but good grief. If they have a history, a grasp of their own history, and we ask them where they want to begin, and they decide they want to jump right into the deep end of the pool, then I think they probably know this one's going to be a biggie. What they more commonly do is just kind of put a toe in. Okay. But they're absolutely, if they walk in part of the 7% and they go straight to the train wreck, okay. My job is just to make sure we got enough time, and we will take it to allow them to do that. Okay, so you'd like to address the whole thing, right? And they know this. Yeah, this was the worst thing that ever happened. I want to go right there. Nothing else compares. All right, very untimidly. And so if they get wrapped around the axle, in 10 minutes, and stay there for an hour. Sometimes, I mean, in some of the cases that I've seen, they actually passed out. They fainted. Okay. They just, I don't have another word for it. They because I'm not providing them with that kind of description. 1 minute they're imagining, reviewing the experience, and the next they're sort of catatonic. Okay. I would never use that word with them, but that means something to us, right? They're sort of sitting there sort of catatonic. And I'm just waiting. Okay. So eventually, and if it goes on for a really long time and it's beyond the borders of my experience, I'll go give them a little nudge. Now the metaphoric nudge is just literally, here are the words, what's happening?
Yeah.
That's it. What's happening?
Mm-hmm. Mm-hmm.
And they feel obligated to account. Whatever, and we continue on. Yeah, so I've never really had to worry about somebody is going to address a piece of their own personal history that is so powerful, so horrible that they won't be able to handle it. They'll come unglued, and I'll have to call the cops on something like that.
Wow. Bob, where can people get training or learn more about TIR?
TIRA.org. Traumatic Incident Reduction Association.
And who are some of the trainers, and are there trainings that go on?
Oh, all over the country, yes.
Amazing.
Yeah.
Okay, so this is something that's accessible.
Yeah, absolutely. And we wouldn't ever want anybody to even try to do what they have read about in this regard without training.
Mm-hmm. Mm-hmm. Of course.
Because some of it is sort of counterintuitive. Yeah.
Okay. Well, everybody, Dr. Bob Moore from Florida on TIR, thank you very much again for providing this very, very thought-provoking and informative presentation for our mental health professionals. And this is something that I still want to learn more about. I feel that I want to pursue this and learn more about it. So I really appreciate that you came on and share this with us.
Well, let's make a date for some real video stuff.
Okay, we'll do that off the air.
Yeah.
Okay, well, good night. Thank you.
Good night. Yeah.